So one of the treatments for an MI is fibrolytics. The American Heart Association goal is to start those within 30 minutes after arrival to ED, if this is the treatment they're choosing to use. Basically, fibrolytics are clot busters. One of the generic name is TPA. It's indicated with patients with chest pain greater than 30 minutes in duration and with a STEMI. And a STEMI is ST elevation and it's an MI. Okay? It's contraindicated in recent surgery or trauma, less than 10 days out from those, or a stroke less than 2 months. It can cause bleeding to reoccur in those surgery and trauma patients, and for stroke victims, it could cause intracranial hemorrhage. So signs of revascularization include abrupt cessation of pain. They may have sudden onset of PVCs or ventricular tachycardia. They have resolution of the ST elevation, so you'll see a segment depression, and then their markers will peak at 12 hours and then start to go down, and that's your troponin and your CK and B. They're also put on anticoagulants to reduce risk of occlusion, including aspirin and clopidogrel. Percutaneous intervention or with heart cath or transluminal coronary angioplasty are the first-line treatment for MI. It is the initial treatment if available, so they have to be open when the patient has the MI. American Heart Association goal is to start 90 minutes after arrival, but many times, especially here in Indianapolis, they get to that cardiac cath lab much faster, which is excellent, and it helps save muscle tissue in the heart. PTCA is coronary angioplasty, and that uses a balloon to compress the plaque. They also may place a stent to keep it open. It is not for everyone, and it depends on the number of lesions and the location of lesions. This is usually good for 1 to 2 lesions. And this slide has a link to a video that you should watch, and it kind of goes through what PTCA does. This is just a reminder that heart catheterizations can also be elective procedures done to prevent MIs. For after a heart cath or after a PTCA, if the patient has a femoral artery access, they're going to need to be on bed rest from 3 to 12 hours depending on the type of closure device. Blood pressure is it's monitored closely. If it goes down, that probably means blood loss is happening somewhere, so it's an important key factor. Also, the groin site must be soft and free of bleeding. If there's bleeding, we're going to apply pressure again. And we also want to check for all pulses distal from the site. So this would be the pedal pulse for the groin site. It's important to get in your S-bar where they felt it, if they had to use a Doppler or if it was palpable. So those are some important points to remember. Also, radial artery access. If they go in that way, there is no bed rest necessary, and they may have an external pressure device. And the picture here on the bottom is the external pressure device for radial arteries, and they use kind of a balloon to hold pressure, and they gradually release the pressure with a syringe. Also, this is using a Doppler to find pedal pulses. We're always going to mark the spot where we found it. Arthrectomy, this is basically the rotor-rooter for our arteries. It uses a special tip during the procedure that actually cleans out the plaque. There are quite a few complications. It can cause bradycardia, hypotension, and possible perforation, and these will also have interventions. So for bradycardia, they will often start a dopamine or epinephrine drip. If they have hypotension, they're going to start a vasopressor like norepinephrine or vasopressin. If there's coronary dissection, that's that perforation, they're going to need immediate surgery to repair. Coronary artery bypass graft. This is an occlusion that's bypassed with the patient's own vessel or synthetic graft. They will be on a bypass machine that takes over the role of the heart, and it leaves the heart free to be made still, and they can actually do intricate sewing of grafts on the heart. The sternum is cut open, and it is a very big invasive surgery. The heart is going to have pacer wires to restart the heart and to continually pace the heart if necessary post-operatively. Blood pressure is a concern, so we're going to decrease the preload, which with IV fluids and red blood cells. We do not want the graft to collapse. That's to help keep it inflated and working. We're also going to decrease the afterload. If it's too high, it can cause leaking at the suture, so they might start them on a nitroglycerin drip. We also want to increase contractility, and so they may use an intra-aortic balloon pump to increase cardiac output, and I have a video of that on the video page. They will have drains. Usually it's a wound vac that they'll have to help heal that mediastinal cut on the chest, and they will have a chest tube because they will have deflated the lung to access the heart. And this is a picture of the conventional surgery. Alternatively, there is a minimal invasive heart surgery. The left internal mammary gland is used to bypass often the LAD or one of its branches, and this just is showing you how they've reattached it to bypass the blockage in the LAD. And then they have a Y graft, and they can use that one artery for multiple grafts. So minimally invasive surgery is less traumatic. The sternum stays intact. They do not need to use a bypass machine, so they aren't stopping the heart. And they have the surgery is much quicker. It's got a smaller incision, and they may use that mammary artery because it's already connected in one area. The next is nursing care after MI. We're going to administer and teach about medications. So you'll need to know what all of these are and examples of them. So amiodarone, beta blockers, ACE inhibitors, calcium channel blockers, anti-lipids, and antiplatelets. Their first diet is kind of light for the first 24 hours. We want them to do deep breathing to prevent atelectasis, and they're going to use IS. We're going to keep the head of bed elevated to decrease venous return and to help decrease the preload. They're going to be on stool softeners because they are on opioids, and they also have decreased mobility. And thirdly, we don't want them to bear down or have a Valsalva maneuver. We're going to promote a calm, restful environment. They're going to have lifestyle changes, including diet, stop smoking. If they're diabetic, we're going to make sure they have more control of their blood sugars. With any MI, we're going to watch for cardiac failure and cardiogenic shock. So, average patients will be leaving the hospital with 5 new meds after MI. So we've kind of talked about some of the same categories, antiplatelets and statins and beta blockers, and they're going to have lots of information on lifestyle changes. And here's some videos. There's one on cabbage, coronary artery disease, MIs, and there's one on 12-lead EKGs. This is really interesting because it talks about our ST elevation. So with heart failure, it is more compensatory mechanisms rather than a true pathophysiology. So it's compensating for problems that the heart may have, okay? And what's happening is the compensatory mechanisms start to fail, and that's when we have heart failure. So in the case of tachycardia, it's limiting. If the heart rate is too high, then the diastolic filling time is low, which decreases cardiac output. Arterial vasoconstriction to maintain blood pressure. It's also limiting because it can increase myocardial requirements. So decreased cardiac output makes our baroreceptors release epinephrine and norepinephrine release. So that's kind of that cycle is happening. And basically, when we have heart failure, that begins to fail. Then we have retention of sodium and water from decreased renal perfusion. This activates the renin-angiotensin-aldosterone system. And then we have myocardial hypertrophy. Basically, this is just muscle thickness. And then we have ventricular remodeling. This means our ventricles take on the shape like a bowl. They become remodeled because they're trying to compensate. So all these are compensatory mechanisms that eventually do not hold up. So the etiology, so the cause of heart failure can be systolic, which would be the impaired contractility. This is more common. This is the heart feeling as a pump. It is caused by coronary artery disease and MIs. Then we have diastolic, which is impaired filling, and this is more caused by hypertension and AFib. So we have left-sided heart failure. The patient is going to have a cough. They're going to have crackles. They're going to have dyspnea, increased respiration, or orthopnea. This means they can't breathe unless they're sitting up. They're even going to have nocturnal dyspnea, so they're going to be dyspneic even while they're resting. They can have confusion, decreased memory, restlessness. Your kidneys are going to hold on to their fluids, so you're going to have oliguria, so you won't urinate. And then our heart will have chest discomfort or angina, increased heart rate, palpitations. You'll hear S3. This is also called a ventricular gallop. You know you're hearing it when you hear the heart say Kentucky. It'll say Kentucky, Kentucky, Kentucky. Normally we hear lub-dub, lub-dub, lub-dub. You're going to have dysrhythmias, low ejection fraction. So we got to remember the left side is the venous return from the lungs. Failure to this is going to cause pulmonary congestion and pressure. All right. So L is the same first letter as lungs. So this one you'll remember, you'll have pulmonary congestion. And this is just a picture of what's happening in the lungs. Fluid is going to leak across the pulmonary capillaries into the alveoli. And in right-sided failure, I always think right-sided rest of body. Okay? You're going to have failure in multiple areas. You're going to have JVD, or jugular vein distension, where it's backing up pressure in the body. We're going to have dependent edema, so we have pressure in our vessels and it's leaking across the capillary line, so we have fluid in the body. We'll have ascites, so that's fluid in your peritoneal spaces. And our BNP, our brain natriuretic peptide, is the ventricular hormone that's secreted by our ventricles, okay? It's going to be really high with systolic failure and normal to slightly increased with diastolic failure. Normal is less than 100, and it's also used for diagnosing and evaluating treatment. This is JVD. This is a slide on ejection fraction. With heart failure, you're going to have reduced ejection fraction, and this is the percent of blood pumped with each beat of the heart. Normal is 55% or higher. This is diagnosed by echocardiogram and cardiac catheterization. This is a picture of cardiomegaly, so the one on the left is normal and the one on the right has cardiomegaly. Heart failure, further complications could be cardiogenic shock because the heart muscle is unhealthy, causing impaired contraction and pulmonary edema. Heart failure causes an accumulation of blood and increases pressure and causes fluid and blood to leak across the pulmonary capillaries into the alveoli. So this is what causes that frothy pink tinged sputum. So our goals are to, our diagnosis is impaired gas exchange. Our goals are to reduce respiration, decrease dyspnea, and have acceptable ABGs. So we're going to give rest, and we're going to give supplemental oxygen. They may be on a ventilator, and we're also going to put them in high Fowlers. Activity intolerance, we need to let them rest between activities. We might have to reorganize our activities so that they're kind of spread out. We should always do vital signs before, during, and after any activity, because if an activity is too stressful on the heart, if the blood pressure is greater than 20 millimeters of mercury higher with the activity, or the heart rate is greater than 20 beats per minute, or if it increases, they have dyspnea, chest pain, and they have a decrease in SaO2. So basically, here's an example. If you take their blood pressure at rest and before you start the activity, and it's 120/80, and then you take it again during the middle of their activity and it's 170/80, it's too stressful on them and we need to kind of back off. The next thing is the low sodium diet. We're going to gradually reduce. We can replace it with things like Mrs. Dash, lemon, or garlic and other things with flavor. Fluid restriction, it's going to be 2 liters or less. We're going to do a daily weight. We want to make sure we're really following policy on daily weights and make sure we're having exactly the same thing on the bed as the other patients. Generally, that's 1 blanket, 1 sheet, and 1 pillow. It may include a telepack if you're on a telemetry floor. And make sure that they have a scale at home. Diuretics, there's furosemide and thiazides. These are loop diuretics. The side effects can be dehydration and decreased potassium. They can also be ototoxic or cause ringing in the ears if they are given too fast via IV. What these do is reduce the preload. Then we have the ACE inhibitors like lisinopril. Their action is arterial vasodilation. Side effects are cough, hypotension, orthostatic hypotension, so we have to be very careful with their first dose. They reduce afterload and prevent the remodeling. Then we have beta blockers. One example is metoprolol. Its action blocks epinephrine effects and reduces arterial vasoconstriction. This one causes fatigue, bradycardia, and hypotension. It reduces the afterload and prevents remodeling. And we also have to watch for it causes bronchoconstriction. So we need to be careful with asthmatics. If they can't tolerate an ACE inhibitor, so they may consider an angiotensin receptor blocker or ARB, or a combination of hydralazine and a venous dilator. So venous dilators are your isosorbide or your nitrates. It relaxes the systemic arterial bed and reduces preload, and it also decreases afterload. Its side effect is hypotension and headache. It reduces afterload, and we're to give the oral on empty stomach. Transdermally, you need to make sure they have no hair in the way of the patch. It's usually removed at night, and we also want to remove it before defibrillation. Then we have our cardiac glycosides or digoxin. Its action is a positive inotrope. A side effect is toxicity. We want to make sure to check the potassium because a low potassium can cause dig toxicity. Signs and symptoms of that is visual disturbance. They might see halos or yellow or green. They may have nausea, vomiting, anorexia, and fatigue. It increases the contractility of the heart, and the dig level is 0.8 to 2. The next one is dobutamine. It is given IV. It's 2 to 20 microgram per kilogram per minute, and it's titrated based on heart rate and blood pressure. It's a beta-1 stimulator, and it improves cardiac output by increasing stroke volume. A side effect could be angina. It can cause ischemia due to increased workload on the heart. It increases contractility. Then we have a left ventricular assist device. This is actually contracting the heart, and it's causing a continuous flow forward of blood through the heart. There is no palpable pulse or measurable blood pressure when they have this device. It can be temporary or permanent. So temporary reasons would be waiting to have a transplant, or permanent as in patients that are terminal and ineligible for surgery. Cardiogenic shock. So this is a very serious kind of situation. You're kind of thinking almost code blue here. We're going to have decreased contractility and decreased cardiac output, inadequate tissue perfusion, and ischemia to vital organs. The cause of this can be a large MI, or end-stage heart failure, or dysrhythmias, or cardiac tamponade. So our cardiovascular system is going to have a decreased, so our blood pressure will have a decreased MAP, or a mean arterial pressure. And how to figure out a MAP is systolic plus 2 times diastolic divided by 3. 60 is needed for vital organ perfusion. They have decreased pulse pressures. Decreased systolic pressure occurs when compensatory mechanisms fail. So sometimes we even need to use a Doppler to find their blood pressure. They'll have an increased heart rate to increase the cardiac output because they don't have any volume. They have peripheral pulses that are going to be diminished to absent because of the decreased cardiac output. There's Swan-Ganz will have a high pulmonary capillary wedge pressure and decreased cardiac output, and we're going to kind of talk about that later. The integumentary, so they'll have cool, pale, clammy, and slow to absent cap refill. Respiratory rate will be fast to help provide more oxygen to the blood, and the depth will be deeper to compensate for metabolic acidosis. They're going to have decreased urine output because the kidneys are going to try to hold on to everything. Our CNS, they'll be restless, agitated, anxious, confused, lethargic. They're going to have cerebral hypoxia, so that's why we have CNS changes. Our labs will have ABGs that show respiratory and metabolic acidosis. This is that time when they're both acidosis. And it's caused by the respiratory failure and anaerobic metabolism. We'll have lactic acid that's high levels, and normal is 0.6 to 1.8, so it's going to be greater than 1.8. Potassium will be elevated because that's what happens when we have an acidosis. Remember, we're hyper on acid. So a plan of care, this can lead to multiple system organ failure or death if not treated early, so we have to treat the cause. So the important thing to do first is the ABCs. We're going to make sure they have an airway and they're ventilating, they have oxygen if they need it. We're going to elevate the feet, so this will be a modified Trendelenburg's. We need to get vital signs, and the only way to get a blood pressure in this situation is an arterial line. They may be given certain medications, so they might be given diuretics if it's a heart failure cause, so that Lasix will draw fluid from the lungs, so we can they can ventilate and oxygenate better. They might be on vasodilators to decrease the afterload, and they might be on positive inotrope agents to help increase the heart rate, increase contractility, and then they might be on vasopressors. This is the last option because these medicines can increase their afterload. It's kind of the last stitch. This would be like dopamine, epinephrine, or norepinephrine. So the intra-aortic balloon pump, I put a video at the end of this lecture, also can help decrease the afterload when the balloon deflates. It also helps increase supply blood to the coronary arteries. So this is just a picture of how it works. You have to do daily x-rays. There's vital signs often, neurovascular checks, IS, avoid hip flexion, and we have to check for migration of that balloon pump. And cardiac tamponade, it's a progressive accumulation of blood in the pericardial sac. It compresses the ventricles so the pumping action is lost. It causes decreased cardiac output and cardiac shock. And so we're going to look for the Beck's triad. They're going to have JVD, an increased CVP. They're going to have muffled heart sounds. Just think, so basically that heart is engulfed in blood, so it's going to be muffled. And they're going to have hypotension. They'll have a lower systolic blood pressure during inspiration. Aortic dissection. So this is a tear in the intima, and it allows blood to enter into the aortic wall. Aortic aneurysm. So this is a normal aorta in this picture, and this is one with an aneurysm. So it's basically a bulging out of the large vessel in the abdomen, and they do various treatments with that so it doesn't grow so large. So here is the repair of the abdominal aortic aneurysm. So it can be with a graft, and they actually suture it, or they can have a endovascular repair. So they have an open procedure and a more micro procedure. Here is some more videos for you to watch. Muddiest points. After PTCA, do we give anticoagulants only in the hospital or for life? And I say for life. They do not want any blood clots to form in those stents. It's only if they have stents that it's super, super important that they take something like Plavix. For cardiac markers, do we take 3 blood draws after the initial draw, or is the initial draw one of the 3? And the initial draw is one of the 3. So when they say troponins times 3, that just means we do it 3 times. Would we not see a T wave inversion before an ST elevation? And that is a no. The progression is on slide 41 of the first lecture. So it kind of goes through normal minutes after the chest pain. That's when we'll see an ST elevation first. And then we'll see hours later. That's when the T wave inverts. Then we have days out, and the T is still inverted, and the Q wave gets larger. It's that same slide. That shows you the progression that you need to know. Here's just a slide kind of explaining the renin-angiotensin-aldosterone cycle. So basically, what it does is it regulates the blood volume and systemic vascular resistance, or SVR. You'll see that a lot kind of throughout some of our videos. So the baroreceptor reflex responds in a short-term manner to decreased arterial pressure, and it's responsible for chronic alterations. And it's got 3 compounds. We got renin, we have angiotensin 2, and aldosterone. So they act to elevate arterial pressure in response to decreased renal blood pressure. So they can decrease salt delivery into the distal convoluted tubule and or beta agonism. Through these mechanisms, the body can elevate the blood pressure for a prolonged manner. So that is what that is. Levophed, is it given due to no blood flow in the periphery, or does it cause no blood to the periphery? And it causes blood to be shunted towards the heart. So it helps increase blood pressure, and it takes the blood from the periphery and uses them for the vital functions. So that's the one. It's called Levophed, leave them dead. It leaves them with dead fingers and toes, and often they even have to have limbs amputated, but it's a last-ditch effort to save the vital organs. So there is a question about the SG increase PCW decrease CO that's on the cardiogenic shock page. So SG is Swan-Ganz. That's the catheter that we learned about first, or the pulmonary artery catheter. It's an increased pulmonary artery wedge pressure. Okay, it's also called pulmonary capillary wedge pressure. And it is 15 to 12. It's on your hemodynamic monitoring page. And so it's going to be increased with decreased cardiac output and cardiogenic shock. So that's what that means.